the fibroid itself, leading to hemorrhagic infarction, necrosis, and acute inflammation. Severe localized pain ensue. This process is called red degeneration, which is called the cutaneous degeneration. It is the most common painful complication of fibroids during pregnancy, particularly during the second trimester of pregnancy. Did you just hear that? We are saying that you are doing your sonar, someone presents with acute pain during that period. The doctors are so worried. Some they think that's a miscarriage that is taking place. Then you have got the history, or you find out for the first time that someone is having fibroids. So what must come to your mind in the second trimester is a red degeneration of a fibroid. So we have the central necrotic area. Then you see the accumulation of free fluid there in the central part of the fibroid. So it causes a lot of pain, this one. So, what are the ultrasound clues for this diagnosis? What are the clues? So, ultrasound is not guesswork, it's not prophecy. It's a systematic way of doing things. So you must have clues before you come up with a diagnosis. Known uterine fibroid, heterogeneous appearance, internal cystic degeneration, mixed echogenicity, increased or absent internal Doppler flow, peripheral vascularity may be persistent, may persist, localized tenderness over the fibroid. So these are the clues if you're doing an ultrasound scan that you might be dealing with a case of a red degeneration fibroid or degenerating fibroid in pregnancy. Known uterine fibroid, heterogeneous appearance, internal cystic degeneration, mixed echogenicity, decreased or absent in Doppler flow, peripheral vascularity may persist, localized tenderness over the fibroid. Did you just get it? Please take this down, write the notes. We are learning. This is learning, guys. This is learning. This is learning. Okay. So now let's go to the ultrasound report. Let's now go to the ultrasound report. So now, examination obstetric pelvic ultrasound. Findings: single live intrauterine pregnancy consistent with 24 weeks gestation, anterior intramural uterine fibroid measuring 8.2 by 7.5 centimeters. So in this case, I am not worried about the pregnancy. My worry is on the red degeneration. You understand? That's why I'm focusing more on that, so that I need you to learn about a red degeneration of a fibroid. Did you get that? A red degeneration of what? Of a fibroid. The findings: single live intrauterine pregnancy consistent with 24 weeks gestation, anterior intramural or fibroid measuring 8.2 by 7.5 centimeters. The lesion demonstrates heterogeneous echotex of the central cystic and hypoechoic areas compatible with degeneration. Minimum internal vascularity with a mild peripheral Doppler flow. Placenta appears normal, no retroplacental hematoma, no free pelvic fluid, cervix remains closed. So now, the impression in this case: 1. Large anterior intramural uterine fibroid demonstrating sonographic features highly suggest for red cutaneous degeneration. 2. Viable singleton pregnancy. 3. Sonographic evidence of placenta, no sonographic evidence of placental abruption. So those are the other things that you should look at. We are going to do the obstetric ultrasound, then you have to look into those things. So pain in pregnancy can be obstetric in nature, or it can be gynecological in nature. So in this case, the fibroid has nothing to do with the pregnancy, so it's gynecological in nature. If it was a pregnancy related issue like abruption, now it's an obstetric issue. So this is to do with the gynecological part in pregnancy. So now, what are the key learning points in this case? A red degeneration occurs most commonly in pregnancy. Did you just hear that? Red degeneration occurs most commonly in pregnancy. It usually presents acute localized abdominal pain. But do not think everything that comes with an acute abdominal pain in the second trimester of pregnancy is radiogenic. It could be something else. It could be an abruption. It could be a miscarriage ongoing. So you must have the whole dictionary in your head of these pathologies. What can be happening? Did you get that? Okay. Ultrasound findings can be subtle and should always be interpreted together with the clinical presentation. You have to marry the sonographic findings with the clinical history and presentation. Don't forget that. So Doppler often shows reduced or absent internal blood flow. Doppler often shows reduced or absent blood flow in the fibroid. Most patients are treated conservatively with analgesia, hydration, and observation, while surgery is generally avoided during pregnancy unless another surgical emergency is suspected. Did you just hear that? So for this case, when someone is pregnant, if you operate the uterus to remove the fibroid or try a mammectomy, obviously the pregnancy will go. So we have to conserve the pregnancy. Then the mother can just soldier on with the pain for some time until they deliver. Then the mammectomy can be done after delivery. So the conservative management is the way to manage radial degeneration in pregnancy, unless the fibroid itself is extrauterine, like say pedunculated fibroid that is not within the substance, the mass of the uterus itself. Ladies and gentlemen, I hope learning is taking place. So add this to the vocabulary of learning. I need you to share this educational knowledge with your colleagues. Don't be selfish. Don't be selfish. We are giving you the knowledge for free. Share this knowledge for free so that we serve a patient. Today you are not a patient, but tomorrow you are the patient. So you need this care, you need accuracy, you need your life to be saved. Thank you so much. Don't forget to subscribe and press the notification on button so that when you upload again, you will be the first to be notified. Thank you so much. In society, we must not ignore men. So they also have got gynecological challenges. So in this quiz session, we have got 10 postmenopausal gynecological ultrasound quiz questions. These are multiple choice. So I want us to attempt these together, and then I will give you the explanations. So this basically is the answer to the gynecological quiz sessions that I gave you previously. So question number 1. So you can see there's a thickened endometrium. Thickened endometrium there. There's a thickened endometrium. So the clinical scenario, a 64-year-old woman presents with postmenopausal bleeding. TVS demonstrates a uniformly thickened endometrium measuring 12 millimeters. You can see what is going on there. You can see what is going on there. So, which is the most appropriate interpretation? A. Normal postmenopausal endometrium. B. Endometrial carcinoma should be excluded. C. Physiological finding. D. Atrophic endometrium. So the answer is B, which is endometrial carcinoma should be excluded. As long as you see a thickened endometrium, you should always exclude endometrial carcinoma. So the explanation: endometrial thickness above 4 to 5 millimeters in a woman with a postmenopausal bleeding is abnormal. Differential diagnoses include endometrial hyperplasia, endometrial polyp, endometrial carcinoma. Tissue sampling is usually recommended. So this is how you are supposed to craft your report. You must always think about an endometrial carcinoma as long as the endometrium in a postmenopausal woman is thickened above 5 millimeters. So question number 2, let's discuss it. The endometrial fluid. So there we have it. A 70-year-old woman has an incidental finding of fluid within the uterine cavity. What is the most important feature to assess? What is the most important feature to assess if you see endometrial free fluid in a 72-year-old woman? A. Myometrial thickness. B. Endometrial thickness surrounding the fluid. C. Cervical length. D. The ovarian volume. Answer is you must assess the endometrial thickness surrounding the fluid. So that could be fluid that is coming. Understanding these 10 pathologies, their sonographic appearance can actually save a life. So let's go deeper into our quiz for the day, our daily quiz challenge. So we've got a case that we have here. A 38-year-old woman presents with heavy menstrual bleeding and infertility. Ultrasound demonstrates a well-defined hypoechoic mass projecting into the endometrial cavity. So look at what we are seeing here, what we are seeing there. That's the endometrial cavity. That's the mass that we have. That's the mass that we have. So what is the most likely diagnosis? A 38-year-old woman presents with heavy menstrual bleeding and infertility. Ultrasound demonstrates a well-defined hypoechoic mass projecting into the endometrial cavity. What is the most likely diagnosis? A. Endometrial polyp. B. Submucosal fibroid. C. Adenomyosis. D. Hematometra. What is the most likely diagnosis here? Endometrial polyp, submucosal fibroid, adenomyosis, and hematometra. Question number 2. A 42-year-old woman complains of severe dysmenorrhea and menorrhagia. Ultrasound reveals a diffusely enlarged uterus, heterogeneous myometrium, and fan-shaped shadowing. So you can see the images that we have here. The images that we have. So identify this pathology. A. Leiomyoma. B. Adenomyosis. C. Endometrial carcinoma. D. Pyometria. What is this? Question number 3. A woman presents with intermenstrual bleeding. Ultrasound reveals an echogenic intracavital lesion supplied by a single feeding vessels on color Doppler. So this is what we have here. This is what we are seeing there. Those are the images. That's the uterus there. That's the endometrial cavity. That's the lesion there. That's the lesion there. That's the lesion that we have there. So what is the diagnosis? What is that? A. Endometrial hyperplasia. B. Endometrial polyp. C. Blood clot. D. Fibroid. What do you think is the diagnosis here? Question number 4. Ultrasound demonstrates several small, thin-walled anechoic cysts within the cervix. So you can see what we have. This is cervix. These are multiple cystic spaces there in the cervix. What's your take? What is that? A. Cervical carcinoma. B. Nambothian cyst. C. Cervical abscess. D. Cervical pregnancy. What is the best choice? Number 5. A 54-year-old woman presents with post-coital bleeding. Ultrasound shows an irregular cervical mass replacing the normal cervix. So you can see what is going here on color Doppler. You can see what is going on here on color Doppler there, on color Doppler. What is this? What is the most likely diagnosis? A. Cervical fibroid. B. Cervical carcinoma. C. Cyst. D. Cervical ectopic pregnancy. What is the most likely diagnosis? Number 6. A teenager girl presents cyclic pelvic pain in the primary amenorrhea. Ultrasound reveals a markedly distended endometrial cavity filled with echogenic fluid. As you can see here, you can see what is going on there. You can see what is going on there. What the most likely diagnosis? A teenager girl presents with the cyclic and primary amenorrhea. Ultrasound reveals a markedly distended endometrial cavity filled with echogenic fluid. A. Pyometria. B. Hematometria. C. Hydrometria. D. Missed abortion. What is the best choice? Number 7. Which uterine anomaly is shown? So you can see here on 3D how it's appearing like. On 2D you can see how it's appearing like. You can see what is appearing like that. So the clinical background: a woman with recurrent miscarriages undergoes 3D ultrasound. A fibrous septum divides the endometrial cavity while the fundal contour remains normal. So this is the fundal contour there that is remained normal. What is the most likely diagnosis? Yes, miscarriage of history of recurrent miscarriages. A. Biconwate uterus. B. Septate uterus. C. Uniconwate uterus. D. Diagnose uterus. A woman with recurrent miscarriages undergoes 3D ultrasound. A fibrous septum divides the endometrial cavity while the external fundal contour remains normal. What's the best choice? Number 8. A ultrasound demonstrates a gestational sac completely located within the cervical canal with increased vascularity. As you can see here, there's the bladder there, and you can see the cervix there. The pregnancy is there. The pregnancy there with increased vascularity, as you can see there. So what cervical pathology is this? A. Inevitable miscarriage. B. Cervical pregnancy. C. Cesarean scar pregnancy. Then D. Naboten cyst. Which one is the best choice? Which is your best choice? Ultrasound demonstrates a gestational sac completely located within the cervical canal with increased vascularity. Is it an inevitable miscarriage, cervical ectopic, cesarean scar pregnancy, or is it an aborted cyst? Question number 9. An elderly woman presents with fever and foul-smelling vaginal discharge. Ultrasound demonstrates echogenic fluid containing debris and gas within the endometrial cavity, which diagnosis best fits the image. So that's our image there. You can see the configuration, the morphology of the uterus there. That is how it is appearing like in the endometrium. You can see how it is appearing like. So A. Hematometria. B. Endometrial hyperplasia. C. Pyometria. D. Endometrial polyp. What is the most correct diagnosis or the most likely diagnosis? In elderly women presents with fever and foul-smelling vaginal discharge. Ultrasound demonstrates echogenic fluid containing debris and gas within the endometrial cavity. Number 10. A post-menopausal woman presents with vaginal bleeding. Ultrasound shows markedly thickened, heterogeneous, irregular endometrium with increased vascularity. So you can see here what's going on in the endometrium there. And you can see there in power Doppler that there is a hyperemia or increased blood flow in the endometrial cavity there. So what is the most likely diagnosis? A. Endometrial hyperplasia. B. Endometrial carcinoma. C. Endometrial polyp. D. Retained products of conception. A post-menopausal woman presents with vaginal bleeding. Ultrasound shows markedly thickened, heterogeneous, irregular endometrium with increased vascularity. What is the most likely diagnosis? Endometrial polyp, endometrial carcinoma, endometrial retained products of conception. What is the best option? Endometrial hyperplasia, endometrial carcinoma, endometrial polyp, or retained products of conception. Ladies and gentlemen, understanding the picture recognition in ultrasound forms the base of ultrasound imaging, and this can save lives of thousands, if not billions, of patients the world around us. So if you understand these pathologies, their sonographic appearances, you are going to make a very huge impact in the society, in the community, and in the workplace where you are working. Thank you very much. Enjoy the rest of your day. Don't forget to subscribe and share our channel. Thank you. It is now to discuss the answers to our ultrasound quiz challenge 1. So let's start with number 1. Which pathology is shown? So the history is a 38-year-old woman presents with heavy menstrual bleeding and infertility. Ultrasound demonstrates a well-defined hypoechoic mass projecting into the endometrial cavity. So that's the mass that is projecting into the endometrial cavity that you are seeing there. That is the mass there. That is the mass. What is the most likely diagnosis? A. Endometrial polyp. B. Submucosal fibroid. C. Adenomyosis. And then D. Hematometria. So the best answer for this, that's an endometrial polyp. That's a polypoid mass in the endometrial cavity there. Question number 2. Identify the pathology shown. So the history, a 42-year-old woman complains of severe dysmenorrhea and menorrhagia. Ultrasound reveals a diffusely enlarged uterus with a heterogeneous myometrium and a fan-shaped shadowing. So we can see here globular thickened uterus with the Venetian blinds there. So what is the diagnosis? A. Leiomyoma. B. Adenomyosis. C. Endometrial carcinoma. D. Pyometria. So a diffusely thickened uterus like that with these Venetian blinds that you are seeing here is consistent with adenomyosis, diffuse adenomyosis. So what does this ultrasound demonstrate? The history. A woman presents with the intermenstrual bleeding. Ultrasound reveals an echogenic intracavitary lesion supplied by a single feeding vessel on color Doppler. So you can see here there's a single feeding vessel there. So what is the most likely diagnosis? A. Endometrial hyperplasia. B. Endometrial polyp. C. Blood clot. Then D. A fibroid. So this is a polyp again. So that one is an endometrial polyp. What is the diagnosis? Ultrasound demonstrates several small, thin-walled anechoic cysts within the cervix. So you can see them there, you can see them there, you can see them there. So A. Cervical carcinoma. B. Nabotian cyst. C. Cervical abscess. And D. Cervical pregnancy. So these are cysts inside the cervix. So if you see cysts which are inside the cervix, that is now what is called the Nabotian cyst. These are Nabotian cysts. Question number 5. Which pathology is demonstrated? So a 54-year-old woman present with post-coital bleeding. Ultrasound shows an irregular vascular cervical mass replacing the normal cervix. So you can see it there, you can see it there. So A. Cervical fibroid. B. Cervical carcinoma. C. Nabotian cyst. Then D. cervical ectopic pregnancy. So the correct answer here is cervical cancer, because you can see hyperperfusion there, which is hyperemia, and the mass that is developing inside the cervix. So here is another case scenario. Question 6. A teenager girl presents with cyclic pelvic pain and primary amenorrhea. Ultrasound reveals a markedly distended endometrial cavity filled with echogenic fluid. So you can see here what is going on there. So there are low level internal echoes within the endometrium like that. So what is the most likely diagnosis? A. Pyometria, B. Hematometria, C. Hydrometria, and D. Missed abortion. So the correct answer in this regard is blood that is within the endometrial cavity. So this is hematometra. Question number 7. Which uterine anomaly is shown? So a woman with recurrent miscarriages undergoes 3D ultrasound. A fibrous septum divides the endometrium cavity while the external fundal contour remains normal. So you can see here with what we have here, and then on 2D you can see here, you can see it again there. So what is the correct answer? Biconate uterus, B. Septate uterus, C. Uniconate uterus, then D. Diagnose uterus. So our correct answer here is septate uterus, because there is a fibrous septum that divides the endometrial cavity while the external fundal contour remains normal. So the fundal contour here appear normal. So this is a septate uterus. Question number 8. What cervical pathology is this? So you can see here we do have got the cervix. You can see here we have got a gestational sac there, and you can see here there is the yolk sac and the color. You can see there is hyperemia there. Question: ultrasound demonstrate a gestational sac completely located within the cervical canal with increased vascularity, as you can see here, as I've already shown you there. So what is the correct diagnosis there? A. Inevitable miscarriage. B. Cervical pregnancy. C. Cesarean scar pregnancy. Then D. Naboten cyst. So we are not seeing a sign of miscarriage there. So the correct answer is cervical pregnancy. So a cervical pregnancy is a pregnancy that is developing within the cervix. So it's a form of an ectopic pregnancy. So it's another form of an ectopic pregnancy. We don't have a scarred line there. So again, this is not an abortion cyst because it's a pregnancy, because you can see the gestational sac there, and the history is also alluding to a gestational sac. Question number 9. Which diagnosis best fits this image? So the history, so there's endometrial gas in the endometrial cavity that you can see there. So our question in the history: an elderly woman present with fever and foul-smelling vaginal discharge. Ultrasound demonstrate echogenic fluid containing debris and gas within the endometrial cavity. So what is the most likely diagnosis? A. Hematometria. B. Endometrial hyperplasia. C. Pyometria. D. Endometrial polyp. So if you are capturing the history of what is going on there in elderly, when the fever, so there's fever, meaning say there's an inflammation process that is happening there. Then there's foul smelling vaginal discharge. So this foul smelling discharge is now consistent with the pus that is being formed within the endometrial cavity, making our correct answer here pyometria. Endometrial hyperplasia is only a thickening of the endometrial cavity above normal. So hematometria is blood collection within the endometrial cavity. Then a polyp is a mass that is got a feeding vessel, and it mostly appear echogenic, as we've discussed before. So the correct answer is a pyometra. So the final question now: we have got a case here. So the history reads like: a postmenopausal woman presents with vaginal bleeding. Ultrasound shows markedly thickened heterogeneous irregular endometrium with increased vascularity. So you can see here, it's very difficult for us to distinguish between the endometrium and the myometrium, and you can see on color Doppler we've got hyperemia or increased vascularity there. So you can see the same configuration morphology there. So now, what is the most likely diagnosis? And read the history again. A postmenopausal woman presents vaginal bleeding. So it's postmenopause and that person is bleeding. We expect that when someone reaches postmenopause, they're no longer bleeding, no longer having periods. So this is abnormal bleeding. Ultrasound shows markedly thickened and heterogeneous irregular endometrium with increased vascularity. A. Endometrial hyperplasia. B. Endometrial carcinoma. C. Endometrial polyp. D. Retained products of conception. So the correct response here is a cancer of the endometrium. So this is consistent with endometrial carcinoma, which is B. Thank you so much, all those who attempted the quiz session. I wish you well. I am going to continue posting the quiz session. So this challenge is got 10 cases. So it's a daily quiz challenge, 1 to 10 on gynecology. So once we are done with this quiz challenge, then we will move on to obstetrics 1. So we will go start with the first trimester obstetrics scan. So enjoy the rest of your day. Don't forget to subscribe, like, share, and comment to our channel. Enjoy your day. Ultrasound mystery case. Meninges disease. Is it a benign tumor or is advanced ovarian cancer? What's your take? So these are ultrasound images for a case in question. We have got an ovary here, then we've got a tumor here, there is a mass there, there's a fibroma here in the ovary there, and you can see here there is ascites around the uterus. That's the bladder there. There is ascites there. That's the uterus and the ascites. You can see that the uterus is floating in ascites. And you can see ascites there. Then there, all of that is ascites. So on X-ray, so you can see on X-ray there is pleural effusion there. There is right pleural effusion, right-sided pleural effusion. So here is the clinical TSA. On the case in question, a 56-year-old, that's the history, postmenopausal woman presents with progressive abdominal distension, shortness of breath, pelvic discomfort, unintentional weight gain, elevated CA125. Ultrasound reveals a large solid adnexal mass with massive ascites. The question is this advanced ovarian cancer or something else completely benign? That's the challenge now. That's the TSA. How do we go about it? How do we navigate when we see such a case in your department? Now, let's go to the comprehensive ultrasound report. Examination, pelvic ultrasound, transabdominal and transvaginal was done. So the clinical history, postmenopausal female with increasing abdominal swelling, dyspnea, and suspected ovarian lesion, malignancy. So you can see the abdominal distension there. Ultrasound findings, the uterus, antevated uterus, normal size, endometrium measures 4 millimeters, no focal uterine masses are identified, right adnexia, a large, well-defined, predominantly solid ovarian mass identified. The measurements 11.8 by 9.5 by 8.7 centimeters. Characteristics: homogeneous, hypoechoic echo texture, mild posterior acoustic attenuation, lobulated but smooth external margins, minimum internal vascular tone color Doppler, no papillary projections are noted, no cystic degeneration, no calcification. The appearance is highly suggestive of an ovarian fibroma or fibrotecoma. So the left ovary, normal appearance, measures 3.0 by 1.9 by 2.0 centimeters with normal vascularity. Ascites, large volume, free intraperitoneal fluid is present involving the pelvis, the paracolligators, the Morrison's pouch, perisplenic space. Fluid appears simple without septations or internal echoes. So the Doppler assessment, minimal vascularity within the solid lesion, ovarian lesion, no evidence of torsion. Additional findings: no enlarged pelvic lymph nodes, no peritoneal nodules identified, no omental cake are demonstrated sonographically. So suggested additional imaging because of the associated dyspnea, chest X-ray, CT chest. These demonstrate moderate right pleural effusion. Differential diagnosis that we can have with ovarian fibroma, fibrotecoma, Brenner tumor, pedangulated uterine fibroid, ovarian carcinoma, and metastatic ovarian tumor. These are the common differentials for Meninge's disease. Why it mimics cancer? The combination of large solid ovarian tumor, massive ascites, right pleural effusion, and elevated CA125 can strongly resemble stage 3 ovarian cancer. So this is one of the most confusing case. So you must appreciate or understand that when you are dealing with Meninge's disease, you must have the ovarian tumor, you must have ascites, you must also have right-sided pleural effusion. So if there is ascites and there is the ovarian tumor without right pleural effusion, now it's pseudo-Meninge's disease. It will be pseudo-Meninge's. So the final ultrasound impression: understanding these 10 pathologies, their sonography. Understanding these 10 pathologies, it is now ultrasound. Ultrasound. Before I jump into today's case, I want to imagine scenario. A young woman walks into the emergency department. She is reported with pregnancy test. She's missed the period and she's experiencing lower abdominal pain with a little vaginal bleeding. Naturally, everyone expects to see a pregnancy ultrasound. But there's one shocking problem. There is no baby in the uterus. So where is the problem? Is she miscarried? Is it still too early to see? Or are we dealing with one of the most dangerous images in early pregnancy and ectopic pregnancy? Today, I am presenting a fascinating and potentially life-saving case of pregnancy of unknown location, PUL. We will carefully analyze the ultrasound images, interpret the beta HCG results, discuss the differential diagnosis, and follow the clinical clues that lead to the final diagnosis. This is exactly the type of case that tests the knowledge of every sonographer, radiologist, obstetrician, and emergency physician. Missing the diagnosis can have devastating consequences, but recognizing the subtle ultrasound findings can save a patient's life. As you watch, I want you to think like the person performing the scan. Pause the video when you see the images and ask yourself, what is your diagnosis, where is the pregnancy, and what would you do next? Leave your answer in the comments before I reveal the diagnosis, and let's see if you can solve this ultrasound mystery. Let's begin. So here's the clinical history. In this case, a 29-year-old woman, gravida 2, para 1, presented to the emergency department with 6 weeks, 2 days amenorrhea, positive home pregnancy test was done, mild lower abdominal pain, light vaginal spotting for 24 hours. No previous ectopic pregnancy, no infertility treatment. So the initial blood results are as follows: beta HCG 1.420 IU per liter, progesterone 12 mg per milliliter, HB 12.8 grams per dl, blood pressure 118/70 millimeters of mercury. So the initial differential diagnosis in this case is very early intrauterine pregnancy, failing pregnancy, complete miscarriage, or even an ectopic pregnancy. So because no pregnancy was identified on ultrasound, this became a pregnancy of unknown location, PUL. The transabdominal ultrasound results are as follows. Findings: uterus was normal, endometrial measures 11 millimeters, no gestational sac, no adnexal mass was identified, no free fluid was identified, neither. So on transvaginal ultrasound, the most important examination in this case. So these are the image findings, as you can see here, as you can see there, as you can see there. Findings: empty uterine cavity, thick decidualized endometrium, no intrauterine gestational sac was visualized. Right adnexal demonstrated a 15 millimeter heterogeneous ring-like lesion, small amount of free fluid in the pouch of Douglas. Left ovary was normal. Then the corpus luteum in the right ovary. As you can see here, that's a corpus luteum cyst that you have there, as you can see. So on color Doppler, you can see the ring of fire there. You can see the hyperperfusion or the hyperemia that we have there. That's the color Doppler. Now, the findings: markedly peripheral vascularity on color Doppler, as you can see here. Classic ring of fire sign, which is consistent with a corpus luteum cyst of pregnancy. So although this sign is not specific, it increases suspicion when combined with positive beta HCG, empty uterus, and an adnexal mass. So the serial beta HCG, day 1, it was 1.420. On day 3, it was 1.6110. On day 5, it was 1.730, meaning that it was progressively increasing, as you can see there. So what's the interpretation now? What interpretation to give? Abnormalize a viable intrauterine pregnancy usually increases by at least 35 to 53% over 48 hours in early pregnancy. This slow rise raises concern for a non-viable pregnancy or ectopic pregnancy in our case. So the MRI is rarely needed in this case. MRI is rarely needed. If done, MRI is not performed routinely, but may be useful when ultrasound findings are equivocal or when evaluation of unknown ectopic pregnancy is done. So if there is an unknown pregnancy you can't see, but the test is positive, then ultrasound, if you can